Hey everyone, and thanks for being here. Whether this is your first training video or you've been through a few, this one is a foundational piece. We're going to unpack what makes group therapy at JADE actually therapeutic and how that's different from other kinds of group experiences that clients might have. Group therapy is a cornerstone of addiction treatment because recovery doesn't happen in isolation, it happens in relationship. Substance use often thrives in secrecy, shame, and disconnection, and group offers a structured space to challenge those patterns. In group, clients practice showing up honestly, hearing themselves out loud, receiving feedback, and building trust with others who get it. They learn that they're not alone, that their struggles make sense, and that change is possible. When facilitated well, group therapy helps clients develop insight, emotional regulation, communication skills, and accountability, all of which are essential for sustaining recovery outside of the treatment setting. So, what makes group therapy therapy? The distinction really matters, not just for how you show up in the room, but for how you talk about group with the people that you serve. A lot of folks coming into our IOP and OP groups have past experiences with things like AA, 12 step, smart recovery, recovery dharma, and those can all be really helpful and we definitely encourage them. But what we're doing here is different. So let's start with looking at the difference between therapy and peer support. When somebody goes to a 12 step meeting or another peer led group, they're entering a shared space of mutual support. There's often structure, maybe a reading or a speaker, but the goal is typically to create connection, accountability, and shared identification. These groups are powerful, but they aren't facilitated by licensed clinicians. They don't follow a treatment plan, and they're not designed to diagnose, intervene, or process at a clinical level. At JADE, our groups are therapy. That means that they're facilitated by somebody trained to listen for change talk, to respond to ambivalence, to hold space for trauma without re traumatizing, and to assess for progress over time. Our groups are rooted in evidence based practice and ethical standards. Clients have a diagnosis, they have documented goals, and we're billing insurance, and that all comes with a responsibility to provide skilled, intentional treatment. And that doesn't mean it's cold or clinical, it's really quite the opposite. Our job is to be human and competent, warm and grounded, curious and clear. We make space for emotion, for truth telling, for transformation, but we're also tracking symptom presentation, change over time, and what interventions are actually happening. And it's tempting to describe group as just like a meeting, but with a therapist. Or sometimes clients will even call it class. And honestly, it makes a lot of sense. For a lot of folks, the last time that they were in a room sharing ideas, listening to others, and learning about themselves in a structured way was in a classroom. But here's the thing, group therapy isn't a class and it's not just a meeting. It's something different, it's something deeper. A group therapy session includes intentional facilitation rooted in theory and ethics. You're not just keeping time or choosing topics, you're making clinical decisions in real time based on interpersonal dynamics, theory, and your scope of practice. Group therapy also includes therapeutic goals linked to a person's individualized recovery plan. Each client is here for a reason, sometimes very different reasons. And what happens in group is meant to support real life behavior change, not just abstract discussion. In group therapy, interventions are tailored to where people are in their process. What you might say to a newly admitted client might look very different from what you would say to challenge somebody who's 3 months in, and that's by design. In group therapy, we're also monitoring mental health symptoms and co occurring disorders and risk level. So, group isn't just about support, it's a space where we're constantly assessing safety, risk, affect, insight, and readiness for change. Group also offers opportunities for feedback, challenges, and corrective emotional experiences. In group, clients don't just talk, they get to hear how they impact others. They practice boundaries, receive support, tolerate discomfort, and learn to stay in connection without using or drinking. Unlike a meeting, we don't just listen, we reflect. We ask questions that evoke meaning and clarify values. We listen for sustained talk and gently lean into ambivalence. We use interventions like linking, summarizing, affirming, reframing, and even silence, not to fill time, but to help people move and shift. Group therapy is active, it's alive, it's relational, it's clinical. It's not about delivering content, it's about creating a space where change can happen. And that's what makes it more than a meeting, more than a class. It's therapy, and when done well, can really change people's lives. And something that we talk about a lot at Jade is the difference between support and dependency. We want our clients to feel safe, seen, and supported in group, but we do not want to become the only thing keeping somebody afloat. Group therapy is a bridge. It's meant to help people build the tools, the skills, and the community that they need to sustain recovery long term outside of our building. So we regularly talk about discharge. We normalize the idea that therapy isn't forever. We talk about step down openly. We invite clients to explore external supports, meetings, mentors, creative practices, spirituality, family, meaningful work. because we know that recovery doesn't work when it's overly reliant on one provider, one space, or one modality. We also acknowledge that leaving can be hard. Some people may form deep attachments to the group or their therapist, and that makes sense. Many people haven't had space that felt safe before. So, part of our role is to name that, to support the grief of moving on, and to help clients honor why they've built it with us, not because of us. So, putting it into practice, when you're leading a group, you're going to want to ask yourself, am I helping clients move towards autonomy or reinforcing reliance? Am I hearing change talk or just nodding along? Am I using my clinical skills intentionally or just filling time? Group is never just a meeting, it's a living relational healing space. And we show up as clinicians, not just facilitators. So that's the intro of why groups. And let's take a look at how the group life cycle shifts and changes over time. Even when it feels like you're leading the same group day after day, you're not. Each group has its own arc, its own rhythm, and its own personality. And we're going to walk through the 5 stages of group development: forming, storming, norming, performing, and adjourning. And we'll look at what these stages can actually look like in a substance use setting across both IOP and OP. And we'll also talk about how you as a clinician can meet the group where they are, not where you wish they were. So let's just do a quick overview of the stages of group. And if you've taken a groups class in your master's program, this will probably sound really familiar. This is Tuckman's 5 stages of group development. If you're also studying for your NCE or any other licensure test, you're going to want to know these. So, starting with forming, people are new, polite, unsure. They're trying to figure out the vibe, the structure, and whether it's safe to be honest. In storming, there's conflict, sometimes subtle, sometimes loud. Clients test boundaries. Some are going to challenge your authority or each other, and it's normal. And then in norming, the group begins to find a rhythm. There's a shared language, unspoken rules, maybe even inside jokes. People are more likely to offer support or challenge one another. And in performing, this is the sweet spot. This is the goal that we want to get to. Clients are engaged, the group is self sustaining, there's safety, vulnerability, and honest feedback. And in adjourning, people leave. Endings are processed, there's grief, avoidance, or regression can often show up here. But this model isn't really linear, especially in open enrollment groups like ours. At JADE, people come and go, and that means that groups often revisit stages. Every time somebody new joins, the group reforms. Every time somebody leaves, the group has to adjust again. And so, looking at how these stages actually play out in IOP and OP. In IOP, there's more intensity, more time together, and usually faster movement through the stages. People might reach the norming or performing stage within a few weeks, and there's cohesion, but there's also more potential for drama, especially in storming. In OP, you might notice that the pace is generally slower. People are seen once a week. It might take longer to form a group identity, and that's okay. It just means that you, as the facilitator, needs to hold structure a bit longer. You'll notice that storming may be less intense or more passive. Norms take longer to stick. And in both levels of care, clients aren't just responding to each other, they're responding to you, your energy, your presence, your willingness to meet the group where it is, not where you want it to be. And this is going to shape how these stages unfold. So, looking at specific client behaviors across these stages, in forming, you're going to notice silence, polite nods, surface level answers. People might repeat cliches like it is what it is or one day at a time just to avoid vulnerability. Clients may rely heavily on you for direction. They might ask you, what are we doing today? Every day. It's really common. In storming, pushback can show up. Clients might interrupt, challenge the group norms, or dominate conversations. Some might withdraw. Tension in the room feels higher, and this is where your job is not to squash it, but to hold it. We want to stay in the present moment, noticing what's happening right now in the room and reflecting it back to them so that they can make meaning of it. In norming, clients start to open up to each other a little bit more. You'll hear references to previous sessions or callbacks to somebody else's story. Eye contact increases, the group starts to take care of itself a little bit more, and members might redirect each other to offer support before you do. In performing, this is where real therapeutic work really starts to happen and becomes really obvious. Clients challenge themselves and each other. Group feedback is taken seriously. Members hold one another accountable, and you, as the facilitator, might take a little bit more of a backseat, intervening with precision instead of constantly managing the flow. And then in adjourning, we're going to watch for drop off, emotional regression, or resistance. Some clients struggle with endings. Others might minimize their growth or suddenly check out of group. This is where naming what's happening, slowing down, and validating their experience is crucial. Saying goodbye well matters. And one of the hardest parts of group facilitation, I think, is knowing when to stick with the structure and when to toss the plan and follow the energy. If a group is storming hard, don't just redirect or distract. Stay in it, help them name what's happening. Hey, it seems like there's some tension here. Can anybody else feel that? If a group is stuck in forming and avoiding depth, gently invite it. Use immediacy. I notice that we've spent the last few weeks talking about everything but ourselves. Is that feeling true for anybody else? And if the group is performing and somebody new joins, expect a shift. Normalize it. Help the group orient to the new member instead of starting over completely. And you don't have to fix every dynamic, but you do have to name it. And that's what makes this therapy and not just a group discussion or a class. As far as timing goes, a gentle confrontation too early might shut somebody down. Waiting too long to name a storming pattern might allow it to calcify into dysfunction. Good facilitators are watching for the right moment to lean in. When a client pauses before answering, when somebody shifts in their chair, when two people in group are circling a similar theme, that's when therapy happens. Being present, attuned, and responsive is more important than having the perfect plan. In fact, the best plans are usually the ones that we're willing to revise in real time. Group isn't static, it breathes, it changes, it grows. Your job is to stay curious, stay grounded, and help the group move, not force it, not control it, but walk alongside it, just like we do with individual clients. So let's shift from thinking about a group's stages to thinking about the group's story. Not just the individual stories that people bring in, but the one the group starts telling together, whether they realize it or not. This is the group's meta story. And the meta story is the emotional and relational undercurrent. It's the why now and the what are we working through together. Even if nobody says it, it's the reason people who've never met all show up talking about shame or grief or loneliness without anybody directly naming it. It's the vibe, it's the echo, it's the through line. In addiction treatment, especially, people often come in with stories that feel fragmented, like trauma, relationships, relapses, court stuff, housing, identity. It can feel chaotic. Your job is to start listening for where things connect, not just within the person, but across the group as a whole. So you can start by asking yourself some questions. What themes are emerging across group members? Are we circling around loss or control or forgiveness? Are people figuring out how to rebuild trust, set boundaries, grieve what they lost while using? When you reflect these patterns back to the group, you help shift the space from parallel monologues to shared process. That's where group moves from surface to depth, from compliance to connection. And to notice these patterns, you'll need to track the group in real time, not with a literal sociogram, unless that's your thing. And it can be a really helpful tool when you're getting started out, but you can also just watch the social flow. Again, ask yourself who talks the most? Who interrupts or changes the subjects when things get emotional? Who offers support but never asks for it? Who do others seek approval from or avoid? Power in groups doesn't always come from volume. Sometimes the person who talks the least holds the most weight. Sometimes the jokester is dodging deeper work. Sometimes a charismatic member ends up co facilitating for better or worse. It matters who people are talking to, not just what they're saying. And noticing that gives you leverage for thoughtful, well timed clinical interventions. So, if you've been trained in motivational interviewing, you're already equipped to recognize sustained talk, change talk, and ambivalence. Group work just gives you more places to notice it. One person shares hope and another immediately dismisses it. That's data. A client says something honest and somebody else rolls their eyes. That's also data. A wave of resistance after somebody's discharge. That's a story. Use your motivational interviewing skills to reflect what's said and what might be underneath. Affirm client values when they emerge. Evoke deeper sharing from quieter members, and summarize and reflect themes to help clients connect the dots. Motivational interviewing in group isn't about applying a script, it's about staying present, curious, and open, and it helps you hear the story under the noise. And eventually, but not always, the group will shift. People stop talking around each other and start responding to one another. Someone shares something real, and instead of silence, they get empathy, or a challenge, or a nod of understanding. This is when the group becomes more than the sum of its parts. At this point, your role changes a bit. You're holding and guiding, but you're no longer the only engine. The group starts to carry itself. People remember details, follow up between sessions, build trust. And when that trust wobbles, you name it and bring it back to safety. And no matter the structure, the clinical presence you bring is what holds that group together. You're tracking who's present, who's pulling back, and what's going unsaid. You're helping people talk to each other, not just to you. That's the long game of group work. Over time, your role should fade as the group finds its own rhythm. And this is where linking comes in. Linking means connecting the dots, Pointing out when clients are expressing similar struggles, even if the language looks different. So, for example, it could look like, hey, it sounds like both you and James are talking about feeling like you always have to prove something. Does that resonate for either of you? Or earlier, Tasha mentioned the fear of letting people down, and now you're talking about isolating. I'm wondering if those are connected. Can you two talk to each other about it? Linking builds trust, turns shame into shared experience, and reminds clients that they aren't alone. And I want to make sure that we're talking about person centered practice because so much of the work at Jade is focused on the client. At the core of strong facilitation is a person centered stance, and that means empathy, feeling with your client, not just listening to them, unconditional positive regard or UPR, respecting clients, even in resistance or regression, and authenticity, being real. The clients are going to know when you're not. These aren't extras, they're essential. They set the emotional tone and model what it looks like to show up without judgment. And therapists at Jade are expected to guide without controlling. The goal isn't to dominate the space. You're not there to be the teacher. It's to let the group become its own support system with you as a steady anchor. And there are a few different ways to lead. Authoritarian leaders control the direction, which may feel safe in crisis, but can shut down autonomy if we do it long term. Democratic leaders balance structure and freedom. They use feedback, reflect group themes, and encourage members to lead. The democratic approach is what we strive for. It supports spontaneity, ownership, and connection. And looking at skills or clinical tools in the group room, some of the ones that I hear new therapists struggle with the most are immediacy and confrontation, and just generally staying with discomfort. Confrontation and immediacy can be powerful when used with care. Confrontation can look like, hey, you said that you want to reconnect with your kids, but you're not ready to stop using. Can we sit with what's getting in the way? Immediacy might sound like, I notice when the group gets quiet, you make a joke. What's it like to sit in silence here? We're really noticing the here and now in the present moment and calling it into everybody's awareness. These skills work really well when trust is already in place. It's not about control, it's not about forcing change, it's just about holding up a mirror. And finally, we want to stay with discomfort. Don't rescue the group too quickly. The magic often happens in the silence, the stuckness, or the tension. Containment and safety matter. You might need to pause to check on regulation, name when the group feels disconnected or overwhelmed, or help the group stay in the moment even when it's hard. So at Jade, we don't run cookie cutter groups. Every group has a purpose, but that purpose shouldn't limit the depth, flexibility, or humanity of how we show up as therapists. We emphasize group process, spontaneity, and authentic engagement over rigid structure, but that doesn't mean that our groups are random or unfocused. So, looking first at the types of group that we facilitate, you'll notice that we don't label groups strictly by a format like relapse prevention or coping skills group, because most of our groups include more than one element. That said, it's helpful to understand the general categories and how they show up in our work. So, groups focus on a theme like grief, shame, boundaries, but still invite a client voice and personal application. Process groups emphasize in the moment connection, feelings, and relational awareness. These require high facilitator attunement and an ability to tolerate silence, emotion, or messiness. Then there's skill building groups like DBT groups, CBT groups, mindfulness groups. They all teach specific tools and techniques. Even these should include space for clients to reflect, share how they're applying the skill, and ask questions. And then there's support groups that offer space for shared experience, validation, and mutual encouragement. They're usually less structured, but benefit from some gentle facilitation to avoid hijacking or venting. We often blend these formats into a single session. For example, a group on boundaries might include a psychoeducation, like a topic, a values card sort, which would be skill building, and then an open conversation about clients' experiences, and that would be process and support. So your clinical orientation is going to shape how you listen, intervene, and engage. And a few examples from common approaches can look like a Gestalt oriented therapist may focus on present moment experience, body language, and relational dynamics in the room. So they might ask questions of like, what's it like to say that here, right now? A CBT oriented therapist might help clients track distorted thoughts or connect patterns between behavior and belief. What story do you tell yourself when that happens? A psychodynamic therapist might bring attention to transference. They could ask, what does this reaction remind you of? Anything from your childhood? If you're using motivational interviewing, your role is to guide rather than direct. At times, sometimes you also want to direct, but you really want to help clients explore ambivalence without pressure. And regardless of your foundation, group therapy at Jade asks you to be present, curious, and responsive, not stuck in a script. And again, you'll notice that we don't use a manualized curriculum, and that's intentional. We avoid curriculum based groups because they can feel more like a classroom than therapy. Our approach allows for flexibility, responsiveness, and creativity, but we still need structure. And here's what structure without rigidity typically looks like. You'll arrive with a loose plan or theme, thinking about client themes from previous sessions or that meta story that you've been uncovering. Generally, we open with check ins, which are more just than how was your day. They help you assess tone, emotion, urgency, and possible links between group members. You link clients to each other and the group's emerging themes. So it sounds like that you're both talking about this tension between independence and connection. You might read a short excerpt, something thought provoking, metaphorical, or thematic. This could be a quote, a poem, a short recovery reading, or something from a client if they offer it. Generally, in IOP, we're going to offer an activity, ideally one that connects to the group's meta story for the day or the underlying emotional or relational thread. This activity should invite reflection, connection, or meaning making. It's not here just to kill time. And you're going to want to close the group intentionally, summarizing insights, offering a final reflection question, or grounding the group with breath, imagery, or stillness. So, looking at different activities that we can choose, let's talk about the difference between worksheets and games and just how to choose the right activity. We're not anti worksheet, but we also don't always want to lead with them. Worksheets can be really helpful when they're integrated into discussion rather than treated like homework. Used to structure reflection, like a value sort, chain analysis, cost benefit analysis, and adapted to meet the group's energy or literacy level. Games and experiential activities can be really powerful too, especially when they foster connection without forcing disclosure, engage clients creatively or kinesthetically, and create metaphors for recovery. But here's the rule: if it feels disconnected from what the group is actually talking about, it's probably not going to work and it's not going to be the right tool for that day. So instead, you're going to want to ask the group, hey, what do you need from this space today? You can offer choices like we could do a metaphor activity around grief, or we could spend more time unpacking the tension from earlier. Pay attention to the energy, tone, and content from check ins. Your activity should meet them where they are, not force them to be somewhere else. We also encourage the use of expressive modalities like art, metaphor, storytelling, movement, journaling, narrative to help clients access deeper insight and meaning. So you can try using metaphor to reframe or explore stuck points. If your recovery was a relationship, what would it look like right now? Inviting group members to draw or visually represent their experience, even in simpler ways, a color, a line, an object, grab some Play Doh. You could ask them to tell the story of addiction or recovering using narrative tools. Tell the story of your substance use as if it were a character. Who is it now? Who was it before? If they were in a movie, what actor would play them? These methods help clients bypass intellectualizing and get closer to emotional truths. They also support clients who process differently, visually, somatically, or symbolically, that may not thrive in talk or discussion heavy groups. And the matrix model is one of the evidence based frameworks that we reference, especially for clients with stimulant use disorders. While we don't follow it rigidly, it informs the way that we organize group themes and think about sequencing treatment across time. We want to encourage peer support and feedback within the group structure. We're going to blend psychoeducation with interpersonal exploration. We're going to maintain a non judgmental stance while holding firm expectations and integrate self help principles, community connection, and lifestyle change. And sometimes that'll include having family day groups where group members are invited to bring family members in. We use the matrix model not as a map to follow exactly, but as a scaffolding to build from. It helps us stay mindful of continuity, core recovery skills, and how each group fits into the broader arc of clients' treatment journey. So now that you know how to structure and facilitate groups and respond to real time client needs, let's talk about the clinical presence and skill it takes to hold that space well. Up next, we're going to talk about clinical tools that make therapy actually therapeutic. So let's talk about something that's always in the room, even when it's not being named, and that's trauma. If you're doing group work in an addiction treatment setting, you're doing trauma work. Whether or not clients label it in that way, their stories, behaviors, defenses, and relationships are all shaped by what they've been through. We don't need to get trauma disclosures to know it's there. We just need to know how to facilitate safely, respond compassionately, and adapt when the room starts to shift. Being trauma informed in group therapy doesn't mean avoiding hard topics. It means building a space where hard things can be shared safely, and this includes pacing. Don't rush deep processing. Slow the group down if things feel chaotic or overwhelming. With boundaries, we want to set clear expectations around crosstalk, feedback, and emotional safety. Group is not where we fix each other. And looking at choice and voice, clients can always pass. They can opt out of an activity, No one should ever feel pushed into disclosure. We're not here to exact stories. We're here to help create a space where stories can be told if the client wants to, and to help the group hold these respectfully. And remember, reactivity, anger, dissociation, silence, or sarcasm might not be resistance. They might be trauma responses. So stay curious. And you're going to see trauma show up in different ways. A client who derails emotionally intense conversations with jokes, someone who checks out or dissociates mid discussion, a sudden spike in tension when the group gets too quiet or too close, hypervigilance around group members' tone, volume, or word choice, and flooding when somebody shares too much too fast and then shuts down. When these show up, the intervention isn't to dive deeper, it's to regulate the room. And that might look like slowing down, regrounding with breath, present moment prompts, or a shift in activity, or offering containment that might sound like, hey, that's a really powerful share, and I want to make sure that we're all able to stay present with it. Let's take a breath together before we respond. So we're not shutting emotion down, we're helping the group to hold it in a way that's sustainable for each person. Sometimes trauma or active symptoms go beyond the group's ability to contain. You may have moments where a client needs to be pulled aside or even removed from group due to safety concerns. Common examples of this might include active substance use or impaired during the group, disclosing recent overdose or suicidal ideation without current support or a safety plan, threatening, aggressive, or sexually inappropriate behavior, escalated emotional dysregulation that's overwhelming to the group or putting others at risk. And when this happens, you're never going to want to leave the group alone. If a client needs to be addressed individually, have a co facilitator, counselor assistant, intern, or other staff member stay with the group so that you can step out with that client. If you don't have a second person in the room, call or text for backup. The CRS team, clinical supervisors, or even a peer therapist can help hold the space. If you were the intern, you may be asked to step in with little notice to support the group while the primary therapist manages a crisis. This is part of the collaborative nature of group work, and you're always going to have support, but you might just not have a lot of time to plan. If you're alone and a client is actively unsafe, prioritize safety first. Remove the client from the space if needed, but keep the rest of the group informed calmly and without disclosing details. You're going to want to say something like, hey, folks, I'm going to pause here for a moment and step out with one group member. We're going to resume shortly. Thanks for your patience. You could even send them on a break outside for 10 minutes. Nobody expects you to handle this alone. We work as a team, ask for help, communicate clearly, and remember that managing a crisis well is part of building trust and safety in the room. Grief is recovery's shadow. It shows up in expected ways: the loss of relationships, jobs, housing, custody. But it also shows up in the quiet moments: the realization that time was lost, that trust was broken, that some things won't be fixed. Clients may not use the word grief, but it's often what they're carrying when they say things like, I don't recognize who I used to be. Everybody moved on without me. I feel empty. Gabor Mate wrote the book In the Realm of Hungry Ghosts, and in that book, he reminds us that addiction is often not about pleasure seeking, it's about pain relief. And grief is one of the deepest kinds of pain. As therapists, we need to make space for that without rushing to make it better. Allowing grief to be part of the process, normalizing it, letting it come in waves, and being mindful that certain calendar dates, program transitions, or peer discharges can stir grief in the group even when people don't name it. And I think here it's important to talk about you as the therapist. You're not immune to the pain in the room. If you're doing group work and you care, which you do, you'll carry some of what your clients carry. And that's not a flaw, that's your humanity. But it means that we need to take care of ourselves and each other. So some practices include debriefing intense sessions with a supervisor or colleague. Say your feelings out loud. Know your own trauma cues. If you feel stuck, numb, overly activated, or like you can't stop thinking about a group or a group member, pay attention. Use rituals to end your day. Close your group notes, take a breath, walk, drink water, be in silence, listen to a podcast on your drive home to get your brain off of it. Do something that tells your nervous system, that was a lot, it's done for now. And remember, the group doesn't need you to be invincible. It needs you to be present and steady. And that means resourcing yourself isn't extra, it's essential. So next up, we're just going to explore how your clinical theory comes into play in real time, not just as something that you learned about in grad school, but as the lens that you use to choose your words, track your reactions, and shape the group's direction. We've talked a lot about the mechanics of group already, how it flows, how to track it, how to listen to it. Now let's talk about how we understand what's happening in the room. because how you see your clients, how you make sense of their behavior, their defenses, their growth, it impacts every choice that you make. This is where theory comes in. And no, theory doesn't mean quoting Freud or pulling out a workbook. It means having a lens, a way of understanding human behavior and change that keeps you grounded when things get messy, because they will get messy. Your theoretical grounding helps you make decisions about pacing, timing, confrontation, interpretation, and feedback. It helps you recognize patterns and chaos. And when group dynamics start shifting under your feet, theory is going to be your compass. As Yalom writes, group is a social microcosm. Clients don't leave their relational patterns at the door, they bring them in, often without realizing it. If someone avoids conflict in group, they're going to avoid it at home too. If someone feels unseen in every relationship, they'll likely reenact that here. And that's the point. Group is a place to see those patterns in real time, to name them, and most importantly, to practice something different. Group can become a therapeutic laboratory for trying out new behaviors and roles. Clients can speak up when they usually stay quiet. They can ask for help without apologizing. They can set boundaries and survive it. They can share grief and feel held instead of judged. This isn't hypothetical work. It's live, it's relational, and it's transformative when done with care. Cognitive behavioral therapy is a practical, structured approach that is a great match for addiction work. In group, it offers language for challenging thoughts, building coping strategies, and reducing shame through normalization. And in groups, you're going to see CBT show up in how we help clients catch and challenge distorted thinking, how we map the connection between thoughts, feelings, and behaviors, and skill building exercises around communication, triggers, and relapse prevention. Clients benefit from seeing that others struggle with similar thoughts. It reduces isolation and reinforces shared humanity. It also gives the group a common framework to support one another outside of just venting. Looking at the Gestalt therapeutic modality, where we're connected on presence, emotion, and contact, it really centers on the here and now, not just what clients are saying or the content, but the how they say it and the what's happening in the room while they do it. And that's called the process of group therapy. So, in group, a Gestalt approach would help you notice patterns in tone, body language, and energy. Use experiments or role plays to explore stuck points. The most common one you may have heard of is the empty chair experiment. And it's going to help you stay with emotions rather than problem solving too quickly. A Gestalt therapist might say something like, "Hey, I noticed the group got really quiet just now. What's happening here?" And this can support Yolom's principle of experiencing in the present, which is often where the most profound shifts will occur. We can look at psychodynamic theory using the group as a mirror. It's about the unconscious dynamics that play out in relationships, including in the group. You're going to see it in transference reactions, a client responding to you like a parent, or maybe responding to another group member like an ex. You're going to see it in repetition compulsion, clients playing out roles that they've always held, the peacemaker, the scapegoat, the invisible one. You're also going to see it when we look at group as a family. The group becomes a stand in for earlier relational systems, offering a chance to rewrite the story. Yalom calls it the interpersonal learning. Clients begin to understand how others experience them and get feedback in real time. When facilitated well, this becomes a corrective emotional experience, a chance to be seen, supported, and responded to differently than they were growing up. And for many clients, verbal processing alone isn't enough. Expressive arts therapies and metaphor based approaches can help unlock material that's hard to articulate, especially when trauma or shame is involved. While we're not going to call it art therapy unless we've gone to school for art therapy, we can use metaphor. So, saying something like, if your addiction were an object, what object would it be? You can invite symbolic check ins. What weather are you bringing in today? Or use narrative exercises or role plays to externalize stuck parts. You can even encourage drawing or imagery to express emotional states. These tools bypass defenses and invite curiosity. They also support Yalom's emphasis on self understanding and emotional catharsis as key mechanisms of change. So, when you're thinking about choosing your approach or your theoretical grounding, it's less about picking the right theory and more about having a lens that you can come back to when the group gets hard to hold. Whether you're primarily motivational interviewing focused, gestalt, psychodynamic, integrative, the point here is to be thoughtful, be rooted, and know what you're looking for. When a group gets chaotic or emotionally charged, pause and ask yourself, what patterns am I seeing? What role is this client stepping into again and again? What's happening between clients and how might that reflect here? Am I responding from my grounding or from my reactivity? And when things go sideways, and they will, theory just helps you stay steady. It keeps you from just managing the hour and brings you back to why you're there in the first place. to help people heal in connection, to rewrite old stories in real time, and to create a space where new ways of being become possible. So let's wrap this up by talking about the end, because how we close group matters just as much as how we open it. Closing group is going to happen day to day, but we also want to look about the big closures, the terminations, the transitions, the step downs, the discharge. All of this is part of the work. So let's talk about how to do it well. So, starting with stepping down, clients don't just show up and graduate. They move through stages of recovery, of change, of readiness. And part of our clinical job is to notice when it's time to shift their level of care. These transitions aren't based solely on time spent or attendance, they're based on progress, needs, and fit. They're meaningful, and when they're handled well, they can become some of the most affirming moments in the therapeutic process. So let's ground this discussion in exam criteria. For IOP or level 2.1, that means that we're providing 9 to 19 hours of structured treatment per week. It's intended for individuals who need frequent contact, support, and structure to stabilize early recovery, interrupt patterns of use, and develop new coping strategies. IOP or level 1 is less than 9 hours per week and is appropriate for individuals with greater stability, fewer acute symptoms, and stronger supports in place. It emphasizes continued growth, maintenance, and integration of new skills into daily life. The intensity of IOP isn't meant to last forever, it exists to meet critical need. And as clients stabilize, the goal is to step down, not stay stuck. In IOP, clients are often early in the stages of change: contemplation, preparation, maybe early action, maybe even pre contemplation. They might still be navigating a lot of ambivalence, managing cravings, dealing with legal or relational fallout, or just learning to get through the day without using. IOP provides more frequent touch points to monitor safety and relapse risk, reinforce structure and routine, support skill development in real time, and build relational accountability. And you might start considering a transition to OP when a client has stabilized acute symptoms like cravings, use, mental health crisis, is constantly attending, engaging, and following through on treatment plan goals, demonstrates use of coping skills outside of group, not just talking about them, and begins initiating insight, accountability, and planning independently. They might no longer need near daily contact to remain stable. And clinically, this often reflects a move from what we call the wall stage of recovery, where the initial pink cloud fades and emotional and psychological challenges emerge, into the adjustment stage, where clients are building sustainable rhythms and routines. In OP, the space between sessions becomes part of the work. The question becomes, can they carry the structure without daily accountability? So clients in OP are often deeper into action or even maintenance stage of change. The tone shifts from crisis management to value-driven choices. You may hear less about cravings and more about relationships, identity, long term planning, and meaning making. You might consider aftercare or community based support when a client has consistent sobriety and strong relapse prevention strategies, is connected to ongoing support systems, meetings, mentors, family, outside therapy, is spending less time in emotional dysregulation and more time in reflection, direction, and contribution. And when they express readiness to transition and see it as a step forward, not a threat. And this doesn't necessarily mean that the work is done. It means that they no longer need the OP group as a container. They've built a scaffold that they can now carry into the world, one grounded in internal motivation, external supports, and lived experience. So, looking at transitions, discharge, whether from IOP to OP or from treatment altogether, is more than logistics. It's a clinical intervention. And like any intervention, it requires preparation. So we're going to want to start that conversation early, even during time of assessment. Maybe asking questions like, what could it mean for you to have fewer group sessions per week? We want to use collaboration to explore ambivalence, hope, grief. Clients may fear that leaving means losing support, even when they know they're ready. We want to look at ritual and create meaning around the transition. Shared reflections, letters to self or to the group, or a chance to offer support to new members. And we also want to look at connection. Help them identify the next steps, alumni meetings, recovery communities, outpatient therapy, or even individual work. We're not just helping them leave, we're helping them understand what they're taking with them. And regardless of level of care, some things are going to stay the same as long as a client is active in treatment. So whether a client is in IOP or OP, most treatment plans are going to include objectives around relapse prevention, coping skills, emotional self-care, and social support development. What changes isn't the goal, it's the intensity and frequency of support needed to pursue it. As clinicians, we're always asking, what level of care does this client need right now in order to make progress on their goals? So now focusing on your role, we're looking at you being steady and not their savior. You are not the glue holding somebody together. You're the mirror helping them to see what they've built. You're the bridge between what brought them into treatment and where they're going next. In transitions, your role is going to shift a little bit too. So you're going to want to be the facilitator, help guide the path and the pace. You're going to be their witness to reflect growth, readiness, and the reality of the shift, and the container to hold the feelings, the clients, and your own that arise as things end or change. This isn't about getting somebody out of your group, it's about releasing them with care, trusting that what they've learned, who they've become, and the connections that they've made are durable enough to carry them forward. And if we've done our jobs well, clients don't need us forever. What they need is what they found in themselves while they were with us. And that's the real work. So, in closing, just thanks for sticking with this training. Group therapy at Jade isn't about filling time, it's about building something real. You're not just a facilitator, you are a steady presence in the room full of people figuring out who they are, what they want, and how to move forward without the thing that they've previously used to survive. That takes a lot of skill and it takes a lot of heart. Yalom says group therapy is a celebration of the human impulse to heal and connection. And that's really what we're doing here. If you walk into each group with curiosity, clinical grounding, and a little courage to stay with the hard stuff, you're already doing the work. So keep listening, reflecting, and stay with the silence. Let the group teach you as much as you're teaching them. You don't have to be perfect, you just have to be present. We are so glad that you're here doing this with us. Let's keep showing up for our clients, for each other, and for the messy, beautiful work of healing and connection.